بسم الله الرحمن الرحيم. معكم دكتور وسام الشافعي, Associate Professor of Menifee University and Fellow of Royal College of Physicians, FSCAI. Today we will talk about protecting our patients with pulmonary embolism. We're having a patient, Mr. Adil is about 75 years old, with recently diagnosed having pulmonary embolism after recent flight, and he's well known to having cancer prostate. Recent labs showing creatinine clearance about 42 milli per minute, heart rate is about 95 beat per minute, and blood pressure about 130 over 70 millimeter mercury. So our patient's profile is acute pulmonary embolism, cancer prostate, and his doctor prescribing him low molecular weight heparin vitamin K antagonists protocol. As we all know from our pharmacological market that the traditional anticoagulation present are: first, unfractionated heparin, which is an injectable form, needs monitoring and dose adjustment, and having a risk of heparin-induced thrombocytopenia. The second element is a low molecular weight heparin, which is also injectable form and needs weight-adjusted dosing. The third one is the oral vitamin K antagonists with a lot of drawbacks like narrow therapeutic window, interaction with food and drugs, and frequent monitoring and dose adjustment is required. So as we told that there is a lot of problems with vitamin K antagonists, as narrow therapeutic window, difficult to keep within therapeutic range, frequent INR monitoring and dose adjustment, multiple drug-drug and food-drug interactions, and slow onset and offset of action, and there is increased risk of bleeding. The recent guidelines of the management of pulmonary embolism in acute phase recommended NOACs over the traditional vitamin K antagonists as the first choice for anticoagulation treatment in eligible patients. And these recommendations takes a class 1A indication. Then after 1 year, Mr. Adil developed another pulmonary embolism. So now his doctor switched him to Rivaroxaban and was asking if injection should be given to him before Rivaroxaban or not. To answer these questions, after observing this chart, we could notice that there is no big difference between Rivaroxaban and enoxaparin as regarding the onset of action. Both of them are rapid, and from that chart we could say that there is no need to initiate with injectable forms. A big trial called EINSTEIN pulmonary embolism study, which is a randomized open-label event-driven non-inferiority study. This study consisted of about 4,832 patients with objectively confirmed pulmonary embolism plus minus DVT. This trial divided the patients into two arms, the Rivaroxaban arm and the enoxaparin vitamin K antagonists arm, with the recommended dosage regimen as we told before. From day 1 to day 21, as regarding Rivaroxaban, takes the dose of 15 mg PID, and after that maintenance dose 20 mg OD. Enoxaparin 1 mg per kilogram PID for at least 5 days, and plus vitamin K antagonist INR targeted 2.5. And 30-day observation period after treatment cessation, and we notice the following. The EINSTEIN pulmonary embolism trial show with the primary efficacy outcome. One of these is the time to first event, whereas the Rivaroxaban was as effective as low molecular weight heparin vitamin K antagonists regimen as regarding symptomatic recurrence vitamin venous thromboembolic events reduction. But what was very striking in this trial is that the major bleeding issue, whereas the Rivaroxaban showed about 51% relative risk reduction in the major bleeding in favor of Rivaroxaban versus enoxaparin vitamin K antagonists. Also, one of these findings is the clot regression following acute pulmonary embolism, where this is the only trial that shows that the novel oral anticoagulation confirming early clot regression following acute pulmonary embolism in comparison with the enoxaparin vitamin K arm. So, when is the highest risk of venous thromboembolic recurrence after the acute event? From this chart, we could observe that the first 3 to 4 weeks after the index DVT pulmonary embolism event, there is a high risk for recurrence. For that reason, that is why Rivaroxaban dosage is covering the first 3 weeks with 15 mg BID to protect patients against venous thromboembolic recurrence. And as we know that in acute phase and acute pulmonary embolism, regimen for Rivaroxaban is 15 mg twice daily with food, and from day 22 transition to 20 mg once daily with food. And as regarding the dose adjustment and renal function, not necessary to adjust the dose except if the creatinine clearance is lower than 15, where the use is not recommended. And now, there is another issue in this patient, which is a cancer state. And what about cancer? And as we all know, in a cancer patient, this is a high hypercoagulable state. And for that reason, the recurrence of venous thromboembolic in patients with cancer is 2 to 9 times higher than in patients without cancer. For that reason, we need to know exactly for how long we will continue on the Rivaroxaban for our patient. For that issue, the SELECT-D trial, which is a phase 3 pilot study comparing Rivaroxaban versus Dalteparin for the treatment of cancer-associated thrombosis. In this trial, about 530 patients divided into two arms, Rivaroxaban arm and Dalteparin arm, and continued for about 6 months follow-up. From this trial, we could observe that there is one of the outcomes was the decrease in the venous thromboembolic recurrence, about 57% recurrence in favor of Rivaroxaban arm versus the Dalteparin arm. And regarding measured bleeding and the fatal bleeding, there is no difference between the two arms. So from the clinical trial, we could conclude that lower incidence of VTE with Rivaroxaban versus Dalteparin by about 57%, same rates of measured bleeding, and after these trials, there was a change in the guidelines, where in 2019 ESC Guidelines for the Diagnosis and Management of Acute Pulmonary Embolism, developed in collaboration with the European Respiratory Society, recommending that in pulmonary embolism in cancer patients, Endoxaban and Rivaroxaban should be considered as an alternative to low molecular weight heparin, with the exception of patients with gastrointestinal cancer, and takes a class 2A recommendations. This is another recommendation for the use of Endoxaban and Rivaroxaban in pulmonary embolism patient and cancer patient. And what if we would like to extend anticoagulation to our patient? This is based upon the underlying provoked situations. If there is a major transient provoked, for example, major surgery or trauma where the risk is low to less than 3%, no need. But while in the minor transient provoked, for example, pregnancy or high flight, and unprovoked no identifiable risk cause where the risk is intermediate from 3 to 8%, and the persistent provoked, for example, active cancer patient where the risk of recurrence of venous thromboembolic events high, more than 8%, in this situation, intermediate risk and high risk, consider extended anticoagulation treatment. So, for our patient, Mr. Adel, in the acute phase, initiate with 15 mg PID for about 21 days. And from day 22, shift to the dose 20 mg OD for 6 months. After that, extend the treatment by about 20 mg OD or 10 mg OD accordingly. But in our patient, continue on 10 mg should be considered for 6 months in therapeutic duration. And lastly, thank you.